Hello, and welcome to the Natural State Podcast. I am your host, Dr. Anthony Gustin. It is my belief that the natural state of any living organism is health, and that our artificial habitat has forced us into having artificial health problems. This show is my attempt to dive deep and learn about using nutrition, sleep, movement, relationships, and more to help you reclaim your natural state of health in a modern world and show you how to thrive in an environment that's stacked against you. If you enjoyed today's show, you can find out more details and information at dranthonygustin.com. On today's episode, I interviewed Dr. Bret Scher. Dr. Scher is a board-certified cardiologist who runs his own clinic as well as his place as medical director at dietdoctor.com. Bret is an amazing human being. He's super open-minded, and he was, sort of like every other cardiologist in 2013, recommending a low-fat, high-carb diet to all of his patients. Was not getting results, so he got some information from his nutritionist and staff and switched everybody, including himself, to a low-carb diet, and the results then just took off. So if this is something that you're interested in, whether you have heart problems, someone in your family does, you're worried about it, you have high LDL cholesterol, you've been having a hard time managing with your doctor, we have a cardiologist on here talking about all things, LDL, saturated fat, etc. So a lot of practical information in this, whether it's looking at your own lipid values or talking to your doctor about how you can manage them. So tune in, and I hope you enjoy. Before we get into today's episode, I wanted to tell you about how you can directly support the show. It is not free to produce this podcast, and I don't want to use the typical model of selling your attention to sponsors to fund the show. I want you to be able to take all of my health recommendations seriously without wondering if I'm being paid to promote something to you. If you want to support the team that is behind this podcast, head on over to either one of the brands that I've founded at perfectketo.com or equipfoods.com. I've developed the products for each of these companies with my insanely high standards because I couldn't find them anywhere else. Perfect Keto offers everything you need to support a whole foods-based ketogenic diet, from exogenous ketones to help you transition into keto and boost your energy, to super clean collagen bars that have been tested not to spike your blood sugar. It's literally the only bar that I know of that won't, and that's why I made it. Over at Equip Foods, we take real food ingredients seriously. You'll find only whole food ingredients like beef protein powder, sweet potato powder, grass-fed liver capsules, and more. If it's your first time trying the products at either one of these brands, use code NATURALSTATE for 20% off your first order. And if you feel amazing focusing on 100% real foods, awesome. These products are intended to support a proper foundation of health and nutrition, and they are not magic pills. All right, enough of that. Let's get into the show. Doc, thanks for coming on the show. Appreciate it.
Yeah, my pleasure. Thanks for having me on.
So why don't you give people a little bit more about your background? I've had a lot of people like Dave Feldman and things like that on the show. I've talked a lot about sort of cholesterol, saturated fat, these things, but you're actually a real board certified cardiologist, right? So I figured you'd have some credibility here on the show as we discuss these ideas, and maybe give a little bit about your background.
Sure. Yeah, thanks for asking. So I'm a board-certified cardiologist and lipidologist. I did my fellowship training back in the day actually in a preventive cardiology training program, which was an Ornish-based program. So very low-fat, vegetarian diet, but with all the other wonderful aspects of the training program about physical activity and stress management and community and quitting smoking and all those other the great parts of it. So that's how I was trained. And when I went into practice, I just thought, here we go, my chance to stomp out heart disease and just help all these people and be the preventive cardiologist. And then sort of reality set in a little bit. And I don't know if I was just too naive or too ambitious, but I clearly was not having the impact on people that I wanted to have. And I had to scratch my head and figure out why. And at first it was just, I don't have the time. I don't have the logistical support. So I started my own wellness clinic in addition to my regular cardiology job, working with a great health coach. And I thought just by giving more time to the patients in that setting, I'd see more benefits. But there were still some people who just weren't getting better. And as I tried to figure out why, the health coach who I was working with, his name's Gustin, great guy, to his credit, he said, well, have you thought about trying a keto diet on
What
these
year
people?
is this?
This was 2013.
Got it.
Yeah. And when he mentioned the keto diet, I looked at him like he had two heads. I said, are you kidding me? I'm a preventive cardiologist. I can't tell people to eat fat. Are you crazy? And to his credit, he just looked at me and said, well, have you actually kind of looked at the science behind it and researched it? And I had to admit, no, it's just what I've been taught and what I believed. But that opened a whole Pandora's box, because once I started looking at it, I saw studies from 2007, 2008, not brand new studies at the time of 2013, the science that had been out there, but just isn't talked about in the medical community. And once I saw that, and then I started reading everything I could get my hands on, and then I said, yeah, we have to try this with these patients who are sort of our difficult, challenging patients.
Well, I mean, credit to you for in 2013 having an open mind about this stuff. And like you said, going back and do it. And I don't know if it was because of your frustration with the lack of results you were getting before. Like, so what was that sort of impetus to explore these ideas and dig a little bit deeper? Because even now in 2020, it's 7 more years of research. It's pretty overwhelming right now how helpful it can be.
Right.
Yet a lot of physicians still are very closed-minded about these topics and very, very strict in sort of bullheaded about their ideas. So like, what was the thing that kept you open-minded about it? Just wanting to get results?
Yeah, it's a great question. I think it was mostly about wanting to get results and being frustrated and needing to find something else. I have to be honest, when I was in medical school and residency and fellowship, I wasn't the guy to question authority. I wasn't the guy to say, is this really true what you're telling me? I was the guy to just take it all in, absorb it, and say, yes, I'm going to do this. You tell me what to do, I'm going to go do it. It took some time for me to sort of develop that skepticism and realize, wait a second, why is this not working? Why am I writing in so many people's charts failure of lifestyle therapy, non-compliant with lifestyle therapy, not seeing results with lifestyle therapy? Why was I writing that in chart after chart after chart? Is it because it was all these people's fault? Or was I giving the wrong message? And there was just sort of this light bulb that went off that said, maybe it's the message. And with the help and guidance of Gustin, my health coach there, he really helped open my eyes to this whole other field that just hasn't been discussed. And once I started having some clinical experience and some personal experience with low carb lifestyles and the benefits it can bring, and saw the research behind it, you can't unsee that once you see it. So
did you start you sort of as a guinea pig for yourself before you put this in your clinic, or how did you sort of ramp this up? Sort
of together. Yeah. I mean, I started myself as a guinea pig, and then with my health coach said, all right, let's try it on a couple patients. And then as I saw the benefits for myself and I saw the benefits for my patients, it was kind of off to the races from there. And I just saw how many people I could affect this way, and how I wasn't writing failed lifestyle therapy, could not comply with lifestyle therapy in the chart nearly as much, because people realize, one of the things we overlook so often is that we are emotional human beings with feelings and cravings and hunger. And those are not good feelings. If you're having hunger all the time and you're battling cravings all the time, you can be following a diet that in a test tube or in a lab environment or a controlled environment is helpful. But in the real world, those emotions come into play. And that's the frustration that a lot of the patients have. But that's what I saw disappear. That's one of the first things I saw disappear. And I thought, people actually enjoy this diet, can stick with this diet, and it's beneficial, right? It doesn't matter if you can stick with the diet, if it's going to raise your A1C and raise your triglycerides and lower your HDL and increase your glucose and do all the wrong things. But it was having all the positive effects, and people were enjoying it more. And I thought, wait a second, this is the intersection I've been looking for of effective, beneficial, and people can adhere to it. And then you throw on top of that, time-restricted eating, which is the simplest of all things to do and effective. And all of a sudden, you've got this great constellation of an effective and doable strategy where I didn't have to write in the chart anymore, non-compliant with lifestyle therapy.
So what was the lifestyle therapy that you were giving before? Like, what were the interventions, and what were the things that you weren't seeing change that you wanted to see change? Was it subjective measures, objective measures? What were you looking at that wasn't changing? And what changed differently after you sort of switched the intervention? Yeah,
the message was lower your fat. You have to lower your fat, and you have to reduce your calories, count your calories, increase the whole grains to help, and the fiber to help keep you full, start exercising more.
Sort of just classical recommendations.
Right. The classic recommendations, because that's what we've been taught. And the markers I was following were subjective and objective. One is, how do you feel? How's your energy level? Are you able to stick with the diet? And then the second was, what's happening to your labs? Mostly from a lab-based standpoint. But, a lot of people just said, I'm trying, doc, I'm just struggling. I just can't do it. I need more motivation. I thought people just, it was a willpower issue, or they just needed more support. So that was the first thing, that from the subjective standpoint, people just weren't able to stick with it as much. And from a lab standpoint, those who did stick with it, their LDL might have improved. And that was we were so focused on LDL, it was like, great, that's a victory. But then once I sort of opened my eyes to the broader metabolic health issue, I realized that, well, their blood sugar is actually getting worse. And obviously not in everybody, but in a number of people that would happen. And so it's sort of like, well, is this trade-off worth it? And as a cardiologist, it was just LDL, 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 LDL with blinders to everything else. So I had to take those blinders down and see people as the whole patient, the whole metabolic health, cardiovascular health kind of wrapped into one. So it was also sort of that awakening that helped me realize there's more to what I'm doing than just trying to drive down LDL.
Right. And so how has that changed over time? And what are you looking at now instead of just LDL, which again is, people have this bad cholesterol in their mind and, it's been pounded into our heads over and over and over again. So how has that sort of panel that you look at objectively changed over the years?
Yeah. A lot of what I do now is just based on characteristics of LDL more than numbers of LDL. Right. And so the size and density, the particle count, the ApoB, what the VLDL is, and these things that aren't talked about or recommended in general cardiology because they're not affected very much by drugs. Same for like lipoprotein little a. So, statins don't lower lipoprotein little a. Statins don't lower the small dense LDL. They don't improve the size and density of your LDL. So if you're only looking at it from a mindset of, does this patient need statin therapy and are they benefiting from statin therapy? Sure, those labs don't really have any significant value. But if you're looking at it from the standpoint of how can I help this patient improve their health without drugs, which is lifestyle, then absolutely those measures are critically important. And the same goes for inflammatory markers, and then using other non-lab markers, but surrogate markers such as a calcium score or a CIMT, and trying to use them creatively, not just a one-time test, but trying to follow over time to measure for progression, because we can do better than just a simple basic LDL measurement in terms of cardiovascular risk, but it's cheap, it's easy, it's universal, and it's affected by drugs. So that's what the focus is on, but we can do so much better. So that's sort of how my perspective has changed with that. But also, more than sort of preventing disease or preventing a number, it's promoting a lifestyle. It's promoting health and happiness and feeling good. And, it's not about deprivation. It's not about trying to balance the side effects of our muscle aches and not wanting to exercise as much with improving the labs. It's about trying to improve quality of life and improve health span and outcomes. And that's the intersection I'm looking for.
Got it. So I'm sure you've switched some people on to a ketogenic diet or high fat diet and have seen LDL increase.
Absolutely.
And so people who are coming from, maybe a different family med doc and then start working with you, what is that conversation like?
Yeah.
When they see that number go up and they, the previous doc, it was, you have to go on statins now or else you're going to die in 5 days, to you saying, hey, it's not a big deal. And like, is there an upper limit when you switch where you just say, okay, 200 is too much, 250 is too much? Do you change your reference range, or is that just not even a marker that you look at for LDLC?
Yeah, great question. So it's definitely a marker I look at. And for people who are these, hyper responders who go on a low carb or ketogenic diet and have an increase in their LDL, it tends to be concordant with their LDL particle number, ApoB. So quick definition, the LDL particle number is just the number of LDL particles, exactly what it says. And that's where all the cholesterol is basically housed or carried. So your total cholesterol concentration is brought about in the specific LDL particles. The ApoB is sort of another surrogate for the LDL particles and other atherogenic particles because they each have one apolipoprotein B on their surface. So discordance is when one is high and one is low, meaning like the LDLC is low, but the ApoB is high, or vice versa. And in concordance mean they track together. So in most of the hyper responders, there's a concordance. So LDLC is similarly, I guess you could say, predictive or effective as a measurement as LDLP. But then the question is, does that matter with no metabolic disease, with low inflammation, with naturally elevated HDL and low triglycerides? Is that as important? And, something, I guess, a little thing where I find myself a little uncomfortable in identifying myself. When I'm in the general cardiology world, I'm the wacko who kind of says LDL doesn't matter. When I'm in the low carb ketogenic world, I'm the wacko who says LDL still does matter a little bit. So sort of like I can't win in these groups because I'm not the one who's going to say you can ignore LDL and it means nothing. I definitely will say it means a whole lot less when all those other markers are good, you're metabolically healthy, you're not eating carbs. It means a whole lot less. But can I say it means nothing? I still can't say it means nothing. So the conversation I have with the patients is not ignore the LDL, forget about it. The conversation I have is, well, let's be smarter about how we evaluate things. Let's make 100% sure that is your only marker that is quote unquote abnormal. And then we can decide what's the best way to follow this to make sure it's not causing any problems with you. Or if your calcium score is already elevated, if you have a strong family history of premature coronary disease, if all your other markers aren't in line, or your biggest concern in life is cardiovascular disease, okay, then we're going to take this LDL a little more seriously. But if you're the flip side of that, then we're going to watch it and just try and be a little bit smarter about how we monitor you. And I think you have to be flexible with the patients to go either way. But definitely not a knee-jerk statin prescription, and definitely not a certain number threshold that once you hit it, you have to be on a statin therapy. I think we can be smarter.
And are you seeing the concordance between LDL-C and ox-LDL as well?
No, that doesn't, I don't see necessarily concordance with, because the oxidation and inflammation tends to be lower in these patients. Now, as LDL particle goes up, your ox-LDL will naturally go up, your small dense LDL will naturally go up, but the percentage is still going to be pretty low. And I think that's the important point. If you can compare pre and post, even if the absolute numbers may be a little higher, but the percentage is a fraction of what it was, that's a victory.
Right. And so, I mean, for instance, Peter Attia does a really good job popularizing this thought of, LDL is sufficient but not necessary for heart disease, and
necessary but not sufficient.
Right. Yeah. Sorry. And so that is something where, looking at that, he I think believes that if that's the case, you should keep it low no matter what, or lower. I mean, what are your thoughts here on this opinion?
Yeah. I mean, on the one hand, it sort of makes sense that if you could drive LDL down to 20 in everybody, that the chances of cardiovascular disease decrease, even if you have inflammation and vascular injury and, small dense LDL and metabolic disease. But the flip side of that is, well, why don't you just get rid of the metabolic disease, the small dense LDL, the inflammation, get rid of all that, then the LDL doesn't matter as much. But the question is, should you still try and drive it down? If you could drive it down in a way where the side effects were making you feel better and having more energy and maintaining your blood glucose and, all good side effects from your driving it down, okay, I guess you could argue that case, but that's not where we are, right? The driving it down comes at a cost. So it has to be a risk-benefit ratio. And when it's the only risk factor with nothing else going on, all of a sudden the risk-benefit ratio really starts to change, I think, in more towards the risk than the benefit for a number of people, not for everybody, but for certainly a majority of the people I see. That's sort of the conclusion we come to with that risk-benefit ratio. It takes a lot more. So if the inflammation isn't there in the first place, the vascular injury isn't there in the first place, the endothelium is healthy, the glycocalyx is healthy. So LDL may still get into the cell wall, but it can come right back out. And the LDL is, if it's responding to an injury, well, if the injury is not there, the LDL is not going to respond and the plaque's not going to build. So the theory certainly makes a lot of sense to me, that you can have people with elevated LDL who are going to do just fine. And I mean, there are plenty of anecdotal reports and published cases of this, that it exists. The hard part is defining it for each individual person.
Right. I mean, sort of the way I think about this too is, let's say you're in your garage and you have a can of gas that's there for your car or lawnmower or whatever, and you start lighting matches and throwing them around. Like, not good. If you keep adding cans of gas, you're going to have how much, and you have 15 cans of gas in there, you're sort of blindly lighting matches and throwing them all over the place. You might have a pretty bad outcome. But if you stop lighting the matches, it doesn't really matter if you have 1 or 5 or 10 cans of gas in there. And so it's just sort of a way I think about it.
Yeah, good analogy.
Yeah, I mean, again, like I don't think we know, or like it's normal to have such out of control bounds. But like you said, looking at some of these other metabolic markers is really important. So as far as, triglycerides, HDL ratio, inflammatory markers, like what are you looking at? So just the reference ranges we have for the general population are probably a little bit different from what you want to see if you see LDL increase in some of these hyperresponders. And so how are these other markers? Do you have sort of reference range in mind? Is it just for the individual in sort of trend lines, or how are you thinking about that?
Yeah, I mean, I don't have reference ranges in terms of like absolute cutoffs.
Mm-hmm.
I definitely want to see progression, because a lot of people I see, they're progressing over time. So you want to make sure things are moving in the right direction. Any triglyceride to HDL ratio less than 1, I think is great. HDL, love to see it above 50 in men, but some people, they're walking around with HDLs of 20. So just to get them up to 35 is a major victory. Not with drugs, not with supplements, but with lifestyle. You can do that with lifestyle. I think you're going to have much more of an impact. So yeah, I guess I don't walk around with absolute cutoffs. I like to see trends for those. Inflammatory markers, CRP, less than 2 is sort of what the standard is. I love to see people less than 1. Mm-hmm. And we could throw out other numbers, but basically it's you want to make sure people are moving in the right direction. And that's why I think a lot of these blood tests, which in sort of general medical practice are not followed, are very important when you're following somebody with lifestyle changes.
Got it. And let's say somebody has all these metabolic markers under control, their LDLC is through the roof. Maybe some concerning things for you long-term, just like you said, make sure it doesn't progress. Do you say, okay, if you're at this age or you have a family history of heart disease, you should, every 2 years get a coronary calcium score, things like that, a CMT, how do you pepper these things in to sort of stay ahead of it to make sure things aren't progressing?
Yeah. So a calcium score anywhere from 1 to 3 years, usually. There is some radiation involved. It doesn't change very quickly necessarily. So you have to factor those in, although the radiation is small. CIMT, the carotid intima media thickness test, has no radiation. You can see progression and regression on a much shorter time frame. So sometimes, even 3-6 months following that. The outcome data is not as good for CIMT as it is for calcium score for a one-time test, but I find it very helpful to follow serially over time. Those are sort of the main two. And then just, of course, following labs over time as well. And how's the patient doing, right? If they're feeling so much better, how many people have you seen that say, I've got my life back, I've lost all this weight, I've gotten off my insulin, I feel I have so much energy. Like that's worth a lot. Mm-hmm. That is worth a lot for a lot of people. And that's when it comes down to promoting health rather than kind of preventing numbers.
Yep. So I sort of want to pause for a second for what you said before about progression and regression. We have a lot that we know now using low carb for diabetes and actually reversing it to a certain degree. I think a lot of people think that once you have plaques in your arteries and all this buildup, that it's stuck there forever. And so what is your opinion here on reversal of atherosclerosis or any heart disease?
Yeah, it's a good question. And data for reversal is poor across the board. There's some data to say statins can reverse heart disease. There's some data to say an Ornish lifestyle program can reverse heart disease. The measures you use for reversing heart disease are so poor in those studies that it's not clear that it's even anything of significance, and it's not clear that it's even outside the potential variability range of the test itself. And that's where I think I just have to sort of shake my head whenever somebody says, vegan diets have been proven to reverse heart disease. Well, no, they haven't. A whole, a comprehensive lifestyle interventional program has been proven to decrease the amount of plaque by a tiny percentage in using a technique that has a huge variability in its measuring error. So that's a different statement than saying It's been proven to reverse heart disease. Now, so can you reverse plaque? You probably can have a small difference in plaque, but to be honest, this may sound crude, but I don't care if your plaque reverses. I care if your plaque stays right where it is and doesn't go anywhere. Because if you have plaque in your arteries, but it is stable and it is not going anywhere, it's not going to affect you. What I care is I don't want you to have a heart attack. I don't want you to have a stroke. I don't want you to have the clinical sequelae of having unstable plaque break off. And that's what we need to prevent. Now, I wish we had better tests for that. We don't have the best tests for that. There's tons of studies going on to try and be able to predict that. But in theory, by becoming metabolically healthy, by reducing inflammation, by improving your health in those manners, you're going to have benefits. And that's where I still will use statins in some cases, in many cases actually, when people have plaque, because regardless of what your LDL is, there does appear to be a plaque stabilizing effect of statins. So that's where I'm not completely against statins, and I think they do have a role. But we can use them kind of more intelligently, I think, than just here's the maximum dose of statin, go, good luck. I hope you don't get side effects. There's definitely better ways about doing it.
Right. So since 2013, when you started implementing this in practice, has your recommendation for the individual regarding their composition of how they get fats from saturated, mono, or poly change at all? Or is there anything that you've learned there?
Yeah. I mean, the whole thing about saturated fat equals evil also doesn't hold up to rigorous science.
Is that something you had to figure out the hard way?
It is. It is.
One way and had to switch?
Yeah, you're certainly not. We're not taught that. We're taught saturated fat is evil. It's as simple as can be. But then you start looking at the work of people like Zoe Harcum, and who did a whole PhD thesis on it. And you look at the quality of the data looking at saturated fat, and it's not nearly as strong as it's promoted. And it's always in sort of this mixed diet, this mixed high carb, high fat diet, which is very different than a low carb, high fat diet. And it's very different when you're eating sort of natural foods and not processed foods. And again, the inflammation's low, the metabolic dysfunction's low. It's a completely different metabolic milieu in which you're digesting and metabolizing that fat. And so the correlation for these epidemiologic studies, just when you have so much confounding variables and healthy user bias, and we say it time and time again with observational studies, and the relative risks are so low, that's not science. That's not good science to make this recommendation that you absolutely have to lower your saturated fat. So the strength of the science doesn't hold up to the strength of the recommendation at all. So if people are eating, whole foods and they're low carbohydrate, I have no problem with them eating a good amount of saturated fats. I think monounsaturated fats are great as well. Polyunsaturated fats, when they come from natural foods, are great. Fish and nuts, sure, why not? I do have a little bit of pause when I see people purposely adding vegetable oils to increase their fat intake and to reduce their saturated fats. To be clear, I don't think we have good human outcome data to say high doses of polyunsaturated fats are dangerous. There's good potential mechanistic data. There's probably even some like mice and rat data. You can look back at some of the older studies like the Sydney Diet Heart Study and the Minnesota Coronary Experiment, where increasing polyunsaturated fats either did nothing to cardiovascular outcomes or worsened cardiovascular outcomes. So there's little hints there, but the quality of the data isn't great. And I think this is where I maybe break a little bit from a number of the people in the keto community, where I need to fall back on the quality of the data and say, yeah, I agree. I'm not increasing polyunsaturated fats myself. I don't recommend it to my patients, but I can't say we have robust human data to tell us that we shouldn't do it. But I worry. I worry if people are going to go low carb and get the majority of the fat calories from these oils that have to go, to extract the oils, they need to use chemicals and extreme heat, and it's just not natural. I just would much rather have people eating natural foods, real foods, and then I have much less concern over what the composition of the fats are. Just make it real foods.
Yeah, I mean, some of the stuff too, just going to this direction, I mean, who's going to fund these studies, right? And that's why a lot of these these weren't funded in the first place, and why we have to sort of figure out stuff. And it seems just to me common sense looking back at what we're meant to eat. And we take, these monocropped vegetables that are sprayed with a bunch of different chemicals that then get processed with high heat and hexane and all this other stuff into a thing where, like we were talking before the show about 4,000 soybeans per teaspoon of soybean oil.
I didn't know that, but that is scary to hear.
A human's just not going to ever eat that. And then you could eat, 8 of those in a meal. So it's just, even if it didn't have all the extra stuff around it, the processing and, manipulating the fat and turning it into this Franken food, and then you're eating it. Like, I think we just all agree that you should eat real food.
Yeah, it's just such an interesting concept. Like, how arrogant are we that we think we can do better? We can create better foods than have been created over the millennia. Like, I don't know. I don't think that's our place to be. And I'm blanking on the name, but that like some Silicon Valley startup like tried to do this and like create some food that was great and just turned out to be an awful experiment. And it was, I remember people at that point were talking about maybe we can't outsmart Mother Nature. Yeah. But I want that discussion to come back. We can't outsmart Mother Nature. Natural food is the way to go.
Yeah, I mean, anyone who's a student of complex systems should know that we're never going to understand what's in food and how it interacts with the human body. And if we did, we would be able to manufacture that stuff and we wouldn't be eating food.
You're right.
I think we would have AI replace human brain at that point. And like, just to think that we can do that and we're smart enough to do so is like you said, very arrogant.
Well, and to consider we're still having the discussion that no, eating fat doesn't automatically turn into fat. Like, that's how simplistic our discussion about nutrition and human metabolism has become. And we're still having that discussion. So we're a little slow to really understand the intricacies as a whole population about metabolism and nutrition.
And has anything changed as far as, you learned all that stuff in 2013, now it's, 2020, we're at this conference, MHS right now, and there's a lot of stuff that's come up. As far as when you first implemented this either for yourself or for your patients, what has sort of been the big phase shifts within lower carb, higher fat that you've noticed change? Or has it been sort of the same? If there's a paradigm shift and it's sort of stuck?
Actually, that's an interesting question. I guess I'd have to reflect on that. I mean, one thing that changed was when I first heard of the carnivore diet, I'm like, these people are crazy. What's going on here? But then it was the same thing. I had to go through the same process. Well, actually, wait a second. Why do I think that? And it's just because I've been taught that. And we need our vegetables and our phytonutrients and our fiber, but do we really? So again, I don't, normally start people on a carnivore diet as like a first tool, but I see it as a tool in the toolkit for certain people. And I don't think they're crazy anymore. Yeah. I'm not going to tell Sean Baker's crazy anyway, but that's all right. But
and so what are your thoughts on it as far as like why would you use it as a tool for yourself?
Well, where I've seen it, from the anecdotal reports is from an immunologic standpoint for an autoimmunity, and the anecdotal reports of its benefits there are pretty remarkable. And I mean, let's face it, plants do have some anti-nutrients and some phytates and lectins, and all those things exist. The harder question is, does it cause a clinical problem for you? Right. And there are some people where it seems to, and some people who it doesn't. I can't pretend to understand why it does for some and why it doesn't for others. I can't pretend to understand, how to predict who's going to do well and who isn't. But I think it's important to have it as a tool in the toolkit for the right situation.
Yeah. I mean, this is the thing where, like, again, if you look at populations all of human history, no one's eaten a fully vegan diet and no one's eaten a fully carnivore diet. And I understand that like some people may react negatively to it now. I think that's more of a manifestation of our environment and growing up in just a completely artificial environment. Our genes change, epigenetic factors, microbiome, all these things are sort of like in a really unnatural state from where they should be, which leads to toxic burden of these things. People also, while eating vegetables, have probably eaten the same, maybe 10, call it 15 vegetables their whole life that are sort of nutrient void, probably full of the same exact exposure to the toxin instead of having the variety, seasonal, local, et cetera. So probably just, if you've seen a lot of clinical stuff around people eating, for instance, they eat a lot of eggs, they start to develop sort of an immune response to eating eggs, same thing. So I don't think humans were ever meant to eat the same food over and over and over and over and over again. And, with the variety of vegetables most Americans know of, or, maybe 5, 6, 7 max.
Yeah, and like you said, all year round. We have access to them all year round, and we can get them flown in from different countries. And talk about the environmental impact of vegetables from that standpoint, but that's a whole different discussion. I probably don't want to open that can of worms. But yeah, it's definitely different from our evolution in our bodies. Some people's bodies react to that in unfortunate ways. I guess, and you asked, what other transformation has taken place with my thought of low carb diets. The other thing that came to mind, and this one happened fairly quickly though, was the concept of keto and low carb means tons of heavy cream, bacon wrapped steaks with, slabs of butter on them. And that was the only way to do it. But it's clearly not the only way. That is a way to do it. And some people do great with that way. But it also means a ton of above ground vegetables with salmon and nuts and olive oil. And, there are all these varieties within the low carb and the keto world that you really can individualize it. And, there was just a paper written recently in JAMA. It was a patient handout paper that I wrote about on dietdoctor.com. And it said there's a danger long-term because people on a ketogenic diet are going to be deficient and have less than the optimum amount of beneficial phytonutrients. And I just had to sort of step back from that and say, well, first of all, no, that's not true, because a keto diet can have an abundance of vegetables with phytonutrients. But second, who's defining the optimum amount of phytonutrients, right? We have essential fatty acids. We have essential amino acids. Otherwise, we have no essential nutrients or food. Phytonutrients are not essential, but that was the assumption, and it was printed in JAMA, and the editors clearly did not question it, because it's just one of these things about dogma. And, there's this hashtag going on now, data over dogma, and that's just one of those other areas where we have to sort of start questioning our beliefs and comments like that, because it really does not hold up at all.
Yeah, I mean, this is one of those things where I'm sort of confused at, you said when you went through medical school, learned all of this stuff, and you had to relearn everything. I mean, have you done any thinking around what it would take to shift the public consensus? Is it just more of what we're doing? Or do we need to change certain guidelines, change curriculums in schools? Like, what have you thought about that regarding this?
Yeah, I mean, what I'm trying to do now is reach the individual doctors and reach the physician organizations to help educate them about low carb, and specifically, carbohydrate restriction, right? Keto right now is a hot topic for good and for bad. Mm-hmm. If you go into a doctor's office and talk to them about keto, they may just put up the blockers right away.
Yeah, what I've noticed is that it's either the doctor's going to be an evangelist or completely against it.
And nowhere in the middle.
There's no in between, yeah.
But if you talk about carbohydrate restriction and means of carbohydrate restriction, all of a sudden that's a different discussion, and they're going to be more open to that. And then it may happen to be a ketogenic diet leads you to carbohydrate restriction, but it's a different way to lead the horse to water, I guess you could say. So right now I have a big focus on just reaching more physicians. Like at Diet Doctor, we just created a CME course on therapeutic carbohydrate restriction. I want every doctor in the country to take this, not because they have to become an evangelist, because they have to know that carbohydrate restriction is an effective tool and relatively easy to implement for your patients. And if we can go doctor by doctor and medical group by medical group and, endocrinology societies, family practice societies, if we can start just educating people about the benefits of carbohydrate restriction, I think the tide is going to turn. And look, the American Diabetes Association has now endorsed carbohydrate restriction as a nutritional tool for glycemic control. I mean, that's huge for the American Diabetes Association to do that. I think that's fantastic. The American Heart Association still lags far behind. Other major institutions still lag far behind, but you got to have hope that it's going to change. And I think it will, especially the more physicians you have involved in practicing it, and practicing it, appropriately and carefully.
Yeah. So like you said before, carnivore can be a tool for autoimmune conditions. And I think that ketogenic diet can be a great tool for metabolic constellation. Have you graded this out as far as anything else could be really, really helpful for as a tool? I think it's a great tool. I don't think everybody needs to eat super low carb or in a ketogenic state. But have you said like, okay, you must be producing ketones for, this set of things. And then carbohydrate restriction, a little bit, not 300, 400 carbs, but 150. Maybe you're not producing a lot of ketones, but it's still a great tool for X, Y, or Z.
Yeah, good question. So from a ketone standpoint, the neurological side of things is fascinating. That's, here at the Metabolic Health Summit, that's what a majority of this conference is about the neurological effects of ketogenesis. And so whether it's dementia of different types or Alzheimer's disease or Parkinson's, or even just depression or bipolar disorder or ADD, the effect that a ketogenic diet can have is actually pretty exciting. Again, we don't have robust clinical trials to tell us that this is absolutely the way to go. But gosh, the anecdotal reports and the clinical experience and the case reports sure look pretty exciting there. And so that's somewhere where I would definitely use it and say ketogenic diet is probably better than carbohydrate restriction and just moderate carbohydrate restriction. And, although if you're eating 300 grams of carbohydrates, cutting that in half, you're still going to see a benefit, no question. Right. And part of that is the quality of the carbs matter. but the absolute amount matters as well. So I think it's a spectrum, and I think we can hurt ourselves more than we help ourselves to say everybody has to be in ketosis and producing ketones. I don't think that's the case, but there certainly are situations where that is beneficial. And like I said, neurological benefits is one. And then for diabetes, you're going to see quicker and more profound results, most likely. Same for weight loss, but it's not that you can't see some benefits with a low carb approach as well.
Yeah. And as far as, we're talking about certain studies with polyunsaturated fats not being done. Are there any in keto or low carb that if you could just wave a magic wand and have information and data, like what would those sort of top studies be?
Oh boy. Yeah. I mean, it would definitely be cardiovascular outcomes with a well-formulated ketogenic diet, because so much of our reliance of whether it's LDL relating to cardiovascular disease, or even if it's, saturated fat and fat in general and cardiovascular disease, they were all in mixed carb fat diets. There was no such thing as studies on low carb diets. And there is perfectly good reason to think it would be different. Absolutely, because your physiology changes, your metabolism changes. So it's a whole different scenario. So that's what I want. I want the cardiovascular outcomes on a true low carb diet.
And how would you structure that?
Ooh, well, I mean,
this is where it gets tricky, huh?
Reality gets in the way, right? You can't randomize 10,000 people to a low carb versus a higher carb diet and follow them for 20 years. I wish we could. Instead using surrogate markers like calcium score, like CIMT, and following it over time. The lean mass hyperresponder population that, Dave Feldman and folks at Cholesterol Code and Siobhan Huggins that they're working with is fascinating, because if anybody should get cardiovascular disease quickly, it should be them. If you're walking around with LDLs of 200, 300, 400, according to our current model, you should develop cardiovascular disease, and probably pretty soon. But if we can prove that that doesn't happen, that's not going to be the data that the lipidology clinic or the lipidology community needs to reverse course. But it certainly should get their attention to sit up and say, maybe there's something to this that we need to look a little more in depth to.
Yeah. And we chatted very briefly before we started recording about a recent study that showed some negative outcomes in the ketogenic diet. Maybe you want to touch on that a little bit, and just to highlight how there can be flaws in the studies with extrapolating information from mice, for example.
Yeah, absolutely. Well, there've been a couple. So there was one out of Harvard recently that said whether you eat low carb or low fat doesn't matter for mortality. What does matter is just the quality of the food. Well, they define low carb as 45% of your calories from carbohydrates.
Which is what the U.S. dietary guidelines say is low carb.
Exactly. And that's high carb. I mean, they have to realize that is still a high carb diet. So sure, if you're eating a moderate high carb or a very high carb diet, the percentages of your macros probably doesn't matter. But to try and extrapolate that to a low carb diet is a bit ridiculous. And prior studies said low carb diets are correlated with increased mortality with the same definition of 45% of your calories from carbohydrates. So that just doesn't help science at all. I mean, those research studies just have to stop being done, because they add confusion and they don't help doctors with the patient right in front of them. It does not help at all. And then the other one that we were talking about, the mouse study, which used a 10% protein, high fat, low carb, with the fat being this soybean oil, hydrogenated soybean oil. And it said, sure, 1 week of using this in mice helped lower their blood sugar and lower certain, T cell inflammatory cells. But after that 1 week, they got diabetes. Their blood sugar worsened. So you better be careful if you're on a ketogenic diet, because this is bad for you after 1 week. So the jump from mice to people is a big jump for starters, right? Just because something happens in a mouse doesn't mean our metabolism is the same and going to do the same. It can be helped to try and look for individual mechanisms, but to say it's going to apply to humans is a bit of a stretch. But then, looking at the composition of the diet, that just stretches it even further. Yeah, if we were eating a diet that was mostly hydrogenated soybean oil, okay, maybe there will be some problems there, but that's not what we eat. That's not what a low carb keto diet is.
We would hope. I would hope. Yeah.
Yeah. But right. That's not what a low carb keto diet should be. So again, the extrapolation just falls short, but gosh, the headlines sure look scary when you see them. And this is the disconnect we have, when people are out to debunk the keto diet by any means necessary, they're going to jump on these headlines and not bother to look at the details or talk about the details. But this is where science, you gotta hope the scientists are well-meaning. They're trying to do science for science sake and put something out there that's going to further the discussion. But a lot of these studies actually kind of halt the discussion more than they help them.
Yeah. So eat real foods.
It's simple, right?
Yeah. And you were talking earlier about obviously we have nutrition, eat real foods, pretty simple. And you said other lifestyle modifications help a lot as well in the cardiovascular outcomes. So like what type of exercise, what type of, stress management, sleep, et cetera, what are these other things that you're noticing are sort of also moving the needle?
Yeah. I mean, they're all so important and so intertwined. Sleep is a big one, and, losing sleep for 1 or 2 nights is not going to be the biggest deal, but it's the chronic sleep deprivation that can really affect your inflammatory markers, your cortisol, and is going to affect your cognitive faculties. And, if you talk about cravings and you talk about hunger and you talk about being able to sort of stay on plan, all those things get a lot worse when you're chronically underslept. So not only is there a physiological reason to focus on sleep, there's also sort of a mental and behavioral reason to focus on sleep. So, I mean, that's very important. And, what I find, there's a definite disconnect. A lot of people know what they should be doing for sleep hygiene, but aren't doing it. And that's why it's important to talk about, to make sure people realize the impact it can have. Stress management is a big one. I liken stress management to exercising. You can try and meditate or be mindful once, and it might help in the moment, but then you're not going to get much long-term benefits from it. Same if you went to the gym once, you might feel good and feel pumped then, but you're not going to get any long-term benefits. But if you can make it a regular part of your life and a regular part of your practice, stress doesn't go away. You're going to still react to stress in some way, but if you can just lower that reaction by 10, 15, 20, 30%, it's going to help you physiologically. And also help you make better decisions. So I think that's so important. And then exercise, again, where I differ a little bit from the keto community is a lot of people run around saying exercise, I shouldn't say run around, walk around saying exercise is not important. And I guess hopefully they realize that that's not necessarily the case, but exercise is not the way to lose weight, especially if you're ignoring your diet. No question about that. But improving lean muscle mass, building muscle, improving cardiorespiratory fitness, those are all important for feeling good, for health span, for longevity. They all play into it. So combining that with healthy nutrition is key. And, the type of exercise, I'm a big fan for mixing it up. Resistance training is so important. But I also think moderate cardio exercise is still an important factor. Some people say cardio is for suckers. Nobody needs to do cardio. I think the cardiorespiratory benefits you can get are still important to do. And then, of course, the high-intensity interval training, for those who can do it, you're getting the cardiorespiratory benefits in about half the time. So that's great. It's a good sort of mix of building lean muscle with the cardiorespiratory fitness. So I like to see sort of a pillar of these things. And actually, we just published an exercise guide on Diet Doctor, and we have an exercise course for beginners, because it's easy to say, yeah, just go do Orange Theory or Barry's Boot Camp and do some interval training. But if you're just getting off the couch and getting short of breath, you're not going to start with that. You need building blocks and stepping stones to kind of get you there and get you started on an exercise program. And you look at people like Ted Naiman and you think, I'm sure plenty of people look at him and say, I'm never going to look like that. Why? But he's great at saying, look, you don't have to do one-arm pull-ups like I do. Just do, wall push-ups to get started. Just do some like chair squats to get started. Getting people started on the process of doing some sort of resistance training, because, there's weight, there's health in there, and there's also just the risk of sarcopenia, losing your muscle mass, falling and breaking your hip, dying from falls, or the morbidity from falls is something that doesn't happen when you're young. It only happens when you get old. And why does it happen? Because most people don't focus on maintaining muscle mass. So I think that's so important to do throughout your life, some version of that. And the other part is social connection. So I love when I hear my patients are out walking with their friends. And, one of the highlights of the week for my wife is to go walk the stairs by this beach, this beautiful beach, the stairs that go up and down, and walk along the coast with her friends. So she gets the social connection and she gets the physical activity. And that's what I like seeing people doing, some sort of combination of that.
So you're talking about stress earlier, and I sort of want to bring it back to that for a second. I was sort of in this camp last year where I just couldn't manage my stress effectively. I had a lot of things going on, both personal, work, et cetera. And my hormones were all messed up. It was brutal. I couldn't figure it out. And then I just took some time off and just stopped working for a couple of weeks. Everything normalized. It was totally fine. But in that time where I was super stressed out, one of the things that you talked about being such a good tool, intermittent fasting and time restricted feeding. What are your thoughts when people are in a really high stress state and also adding in fasting and or time restricted feeding?
Yeah, great question. And, again, it's not an area where we have a lot of studies, but it certainly makes sense and something that I've seen clinically as well. In periods of high stress, that's not when you want to pull the lever of fasting harder, right? That's when I have plenty of people who go 2 meals a day, 1 meal a day, where they are not sleeping and they're stressed and they've sort of hit a stall and they're feeling terrible. That's when I'll say, go back to 3 meals right away. Go back to 3 meals. Let's get you past this hump and not add any potential stress to you. And then we'll go back to 2 meals a day or, do an 18-6 or, change things up back to the way they were when you've gotten past this hump here. So I think that's important. Just because a tool is good doesn't mean it's always good.
Right.
And so I think I like what you're getting at there. And I think it makes sense that there's a right time to back off as well as a right time to push on the gas pedal, right? Like some people start on a keto diet and they're doing well, and then they kind of hit a stall, either from a weight standpoint or from a glucose management standpoint. Maybe that's the time to do an alternate day fasting period, as long as all the other markers are in place. They're sleeping, they're exercising, their stress is good. All right, let's do an alternate day fasting for a few weeks and see if we can kind of kickstart this and then go back to what we were doing before. It's a tool to be used in the right circumstance.
I just think a lot of these things that people, rightfully so, label as health hacks or tips or whatever, fasting, cold plunge, sauna, exercise, etc., are all inherently stresses to the body, which is a good thing if your body can handle the stress adaptation. And this is where I think that people think that fasting is just something that you should do all the time, especially like you're talking, people compare themselves with the people who are doing fasting. People say, oh, I'm not going to look like Ted Naiman or whatever. I want to look like this person who's fasting. And they're not comparing themselves to where they're at and where they need to be. And sort of resetting and creating new expectations for themselves of, here's where I am today and here's where I'm going to go. Is this the tool for me to get there?
Right. And that's a great point. And setting expectations is key. Another guide we have at Diet Doctor is healthy weight loss and expectations. That we shouldn't be comparing ourselves to people we see on social media. We need to compare ourselves to our own control, and how we look and what our body weight is not always completely under our control. So we have to look at other markers of success or other markers of progress, and not just try and keto harder or fast harder to get to these sort of subjective goals that have been created, but to try and be a little more realistic about it. Yeah. And you brought up saunas. I have to confess, I've looked into the research on sauna. I talk to patients about sauna sometimes, but God, I hate saunas. You're never going to catch me in a sauna. that heat.
What did you like about it? Just uncomfortable or what?
Yeah, I just feel so uncomfortable in there. I'm just like, after a couple minutes, my brain just says, get me out of here. So even if it's beneficial, you still have to be able to tolerate it. So I'm not doing any saunas anytime soon, even though the data seems good. But for those people who can, I recommend it. But for me, it's more stress than benefit.
Yeah. Have you tried infrared before?
I haven't tried infrared. Maybe that would be different.
Yeah,
but
so I have one and it goes about 150 degrees. I sweat way more in there than I do in actual like hot, like a 200 plus degree sauna, and I can stay in there for way longer. So I just go in there and read at night most nights. And I notice like my sleep, Tret and Oura Ring and HRV are all improved drastically. My recovery from my workouts, things like that, did not work very well when I was super stressed out last year. Like made me more fatigued, especially I lived in Austin, so it was like 120 degrees. I'd go play basketball outside for like an hour and then go in the sauna. It was too much. I was on the verge of having a heat stroke most days.
That doesn't sound like fun.
Yeah, but the infrared sauna for me, I use Sunlight in saunas. There's Clearlight, a couple other ones that are super small units. Highly recommend those.
All right. Well, next time I'm in Austin, I'm coming over for an infrared sauna, but not in the summer.
So for people who, for example, go to their doctor and they get this blood panel and their doctor says, okay, you have to go on a statin. What do you suggest people to do? I mean, do you guys have printouts at Diet Doctor that they can like bring in and train their doctor? Do they say just go find a new one? Do you say try to work with them? Like, what are the steps and like sort of a flow chart that they can follow for ways to change their health? They want to do this.
It's a great question, and it's a tough question. We do have lots of material at Diet Doctor to help guide clinicians through sort of what the biggest concerns are about keto diet and how maybe some of them are accurate and many of them are not. Guide for skeptical doctors. and guides to try and help doctors see things from the broader perspective of metabolic health and cardiovascular risk in general, rather than just one risk factor. So we have lots of educational materials for doctors that we want patients to bring to their doctors to help educate people. But what we don't have is to say, you can ignore your LDL and you should never take statins. That's not a position I'm comfortable taking. And not a position diet doctor is going to take, but things do need to be individualized. So, what I recommend to patients is engaging your doctor in an experiment, right? If you walk in and they say you need a statin, say, well, hang on a second, let's work together. Maybe we can do another 3-month experiment, 6-month experiment, whatever the case may be, to see how things are changing, see how my metabolic health is. Let's get a calcium score. Let's get a CIMT, see if anything changes. Let's be a little bit smarter about this rather than doing a knee-jerk response. And look, we just published an article on in Diet Doctor on lowering your LDL on a low-carb diet. So for those people who want to lower their LDL but don't want to give up their low-carb or keto diet, we run through a list of things that you can try for that. And
is it what, like increasing monounsaturated versus saturated fat and things like that?
Right. So decreasing saturated and increasing monounsaturated fat, instituting time-restricted eating, increasing fiber, whether it's from psyllium husk or whether it's more fibrous foods, being a little more liberal with your carbohydrate intake. There are certain tools you can use and supplements you can try. And so engaging your doctor as sort of an active participant in an experiment rather than saying, no, I think you're wrong, I'm ignoring you. It's a completely different discussion that you can get your doctor on your team a little bit better if you engage them in that. And so bring them this guide on lowering your LDL on a low carb diet and say, hey, let me give this a try and see if I can do this on my own. And because I'm still getting these benefits from a low carb diet, why would I want to give that up? And I don't want to jump to a prescription yet. If that's you, then I think it's worth trying.
And I've had a lot of people that I've chatted with who have tried that, and the doctor still says, nope, you're going on a statin. This is what you need to do. And they should probably just find a new doctor, I would assume. I don't know what your recommendation is at that point of the flow chart, but
yeah. Look, I mean, there have been plenty of people who I've recommended see a new doctor, which is sometimes difficult to do, unfortunately. Right. But, doctors, we have to be honest. We don't know everything, right? We have to be honest and open-minded in certain situations. And, back in the day, 30, 40, 50 years ago, doctors said and patients did. That's not the atmosphere anymore. Patients want to have an active role in their health and an active role in their health care. And we should applaud them for that. And we should help them. And if we disagree, the doctor can always fire the patient. The patient can always fire the doctor, or we can try and be civil about it and find a way to reach a compromise to do a testing parameter for a few weeks, a few months, whatever the case may be. But you're right. Sometimes you just need to get a new doctor. And look, now there are, like myself, doctors who are doing telemedicine consults where you don't necessarily have to live down the street to be able to come see us. So you can get second opinions. You can follow with us to help manage some of these conditions that require a little more nuance or a little more discussion. Problem is it's not everywhere, and insurance is a pain. And this is the healthcare institution we live with right now. So it's definitely far from perfect.
Yeah. And the work you're doing there, so Diet Doctor, you're publishing a bunch of guides. You said you're doing CMEs. What is the other work you're doing for Diet Doctor?
Yeah, so at Diet Doctor, I'm the medical director, and basically it's ensuring that our content is the most trustworthy and the most reliable on the internet, which I think it is. I think we're doing a fantastic job. We evidence-base all our guides, but we don't just throw up studies and say, here's a study that proves this. We rate the quality of the evidence, because you need to know as a reader, is this, a mouse study? Is this a human study? Is it a randomized control study? Those things matter. And we try and present, opposing sides, that we're not just going to close our eyes and be dogmatic. We want to be open to it. We have a, medical review board with people who are not necessarily low carb fans, and we want them reviewing our content and giving us feedback. So that's part of my job at Diet Doctor, to make sure that we've got the most trustworthy content out there. And like I said, opening the door to more physicians and getting involved with physician education. And then at lowcarbcardiologist.com, that's where I see telemedicine consults, sort of one-on-one patient interactions. I still like clinical care. I love my work with Diet Doctor. I love that crew. But I still enjoy clinical care as well. I don't want to give that up. And I really enjoy these complex problems that tend to walk through the door to find me.
Yeah, it keeps you sharp. Yeah.
Absolutely.
And appreciate all the stuff you're doing. And, most importantly, staying open-minded. I mean, I think that as long as people have that mentality, they'll find the path. And if we figure out in 20 years that low carb is actually terrible for you for whatever reasons, you still stay on top of that and admit that, okay, I just want the truth. You're always going to move forward.
Absolutely. And I think that's so important. That's so important. Like, even if we believe something deep to our core, we have to be open to evidence saying that maybe we're wrong. But again, just little shreds of evidence that are misinterpreted is different than saying, good quality evidence proving we're wrong. And that's sort of the conflict we're in with a lot of these major health organizations, but we have to be open to that just like they do.
Right. Appreciate your time, Doc.
Yeah, thank you. It's been a pleasure.
Thanks for listening to this episode of the Natural State Podcast. Hope you enjoyed it. And if you did, I'd really appreciate you heading over to whatever service you're listening to this podcast on, dropping me a 5-star review and your thoughts on the show. This helps us get discovered by more people and spreading the good gospel of health. And if you want to stay plugged into all of my self-health experiments, recent research and books that I'm reading and my interpretations of those things, products that I'm testing, and thoughts on all things related to health, check out my free weekly newsletter called The Feed. You can sign up for that at dranthonygustin.com/thefeed. That's dranthonygustin.com/thefeed. Thanks again for tuning in and your support of the Natural State Podcast.